Hello, everyone. It's 12 o'clock. We're going to go ahead and get started. Thank you for joining us today. I'm Jody West, and this is the provider to provider consultation line teleecho focusing on perinatal mental health. And today our focus is on perinatal loss. I want to welcome everybody. We're going to go through a few introductions before we get started with our didactic today. I am Jody West, and I am the coordinator for the ECHO, but I'm also the program manager for the provider to provider consultation line. This is our agenda. We're going to do our best to stick to the timing, because we go through a lot of information during this session. We are recording it, and we are tracking your attendance through your signing in through iEcho. So just for some brief introductions, like I said, I'm Jody West, and I am the coordinator for the ECHO and the program manager for the PCL, provider to provider consultation line. We host this training. We are a mental health consultation program that's statewide, where providers like yourself, medical, mental health, anyone that works with families, patients, clients can contact us for any questions regarding mental health for their perinatal clients. And perinatal is pregnant and 1 year postpartum, as well as pediatric. That's another service that we provide, and pediatric is 0 to 21. So if you scan this QR code, if you're not already registered with PPCL, you can scan that code and register with us, and we can send you updates through our newsletter, as well as let you know of other training opportunities that are available with free CMEs and CEUs for those of you that may need them. So I'm going to leave this slide up, and I'm going to introduce Dr. Olivier, who is our facilitator, and I'll let her introduce the rest of the hub team, which are the planners for this meeting.
Hey everyone, thank you for joining us again on your lunch breaks. I'm Dr. Olivier. I'm a psychiatrist in private practice over in Lafayette, Louisiana. I'm also the facilitator for this session, so I'll be managing the clock and trying to help us stay on time. As always, I'm going to ask the hub team to reintroduce themselves to everyone. As your hub team, we like to represent different aspects of the mental health profession. And so we have a couple of psychiatrists, a few social workers / therapists, and also a nurse on our hub team. And so you've met Jody already. She's also one of our social workers on our hub team. How about Lena? You want to introduce yourself?
Or Hi, everybody. My name's Lena Riggett. I'm one of the mental health consultants for PPCL and also do a lot of the IT for our ECHO sessions. Thanks for having me.
Thanks, Lena. Also, another therapist / social worker on our team is Katie Abear.
Hey everybody, I'm Katie Abear. I am a social worker and perinatal certified working in private practice in Lafayette.
And also our other psychiatrist on the team, Dr. Finelli, who is also presenting our case today.
Hi, thanks, Juliana Finelli. I'm a child psychiatrist and a general psychiatrist. My focus is perinatal psychiatry and infant and early childhood mental health. And I work with PPCL as one of the perinatal psychiatric consultants.
Awesome. Thank you, Dr. Finelli. And also Dr. Zena is a member of our team, and she may be joining us in a bit, but she's representing psychology and nursing on our hub team. And so keep an eye out for her. But we're going to roll right into the didactic portion of this session. Another of our social workers, perinatal mental health specialist, Haley Verrett, is presenting today on perinatal loss. So I'm going to turn it over to you, Haley, for the next 20 minutes.
Thank y'all for having me. Before we get started, I do want to acknowledge that this presentation is a delicate subject and can be triggering for those watching and listening, and it impacts a lot of people. So if you've been impacted or you love someone who has been impacted by perinatal loss, I hope you take good care of yourself today and into the evening. And also, language that we use in bereavement care is really important. So I'm going to try my best to use birthing parent and non-birthing parent and baby. However, when you're working with individuals experiencing perinatal loss, I want you to use the language they're using. So if they're saying embryo, fetus, baby, infant, child, I want you to use those words. If they're identifying as mom, dad, spouse, partner, birthing parent, I want you to use those words. We'll jump right in. Next slide. So let's start by defining perinatal loss. This is a death or loss of a fetus or baby that occurs anytime from conception through the 28th day after the baby's born. So it's an umbrella term, and it generally encompasses different forms of loss. And this can be infertility, an IUI, IVF, embryo loss. And we could do a whole presentation just on that, honestly. And then the ones we'll cover today include miscarriage, ectopic pregnancy, stillbirth, and newborn death. And we won't have time for the final two, but they are just as important. Termination of pregnancy for medical or non-medical reasons, and then the losses that can occur during fostering, surrogacy, or adoption. Next slide.
Haley, would you be able to turn off or others turn off their video? The sound is distorted for me. I don't know if it is for everyone else, but we just want to maximize what we can hear and read, if you don't mind. See if that helps, please. And I'll go ahead and promote the slide.
Miscarriage. This is also known as an early pregnancy loss. It usually occurs within the first 12 weeks of pregnancy or first trimester, and that's why it's commonly referred to as an early pregnancy loss. However, the legal state definition for Louisiana of miscarriage is the loss of pregnancy or death of a baby up to 20 weeks gestation. So it can expand past that first trimester, and that's really important to remember when we're working with these families. This is when the fetus or infant is born without fetal heart tone. So there's no heartbeat for the baby. And it usually occurs spontaneously. A lot of time, these families don't have a true answer as to why it happened. And when you think about that from a trauma or grief-informed lens, you can see how jolting that can be for the family.
Jody, we lost the slides. Oh,
There we go.
there we go. Sorry about that.
That's okay. So how often is this occurring? This usually occurs between 10 to 20% of pregnancies will result in miscarriage. That's about 1 in 4 pregnancies. So it is happening often and all around us. You might have a client or patient present and say that they experienced a molar pregnancy, a chemical pregnancy, blighted ovum. I won't get into the details of those today for time, but those fall under the umbrella of a miscarriage. I also wanted to mention what the treatment options would be. If you're a frontline worker, then you know probably what the treatment options are. But if you're not a frontline worker, it could be really important to know what kind of decisions your client or patient were faced with. So they can choose to have the expectant option where they're informed that the miscarriage is occurring and the birthing parent chooses to return home, and they will deliver their baby at home. Sometimes medical interventions are offered via medication to help with that expectant delivery, either at home or sometimes in the medical facility. Depending how far along they are in their pregnancy, some providers will also offer to induce labor, and the birthing parent would vaginally deliver in the hospital setting. Or sometimes they're offered a surgical option, which would be a D&C procedure where their provider would go into their uterus and extract the remains of their baby. So those are important to know if you're working with these families, what their options are, how those were presented, and the impact those choices can have. Next slide. Ectopic pregnancy. This is also known as a tubal pregnancy because over 90% of the time, the fertilized egg implants in the birthing parent's fallopian tube. And so that fertilized egg implants somewhere outside the uterus, usually the fallopian tube, and therefore cannot fully grow and develop to term. Ectopic pregnancies are usually treated as a medical emergency and are considered high risk for the birthing parents. Because if that egg is in a fallopian tube, now we're looking at that tube possibly rupturing and leading to an infection for the birthing parent. An early indicator that the birthing parent might present with is really bad abdominal pain, severe cramping. This occurs in approximately 1 in every 50 pregnancies. And it's important to note that if someone experiences an ectopic pregnancy, it puts them at higher risk for a future ectopic pregnancy. And also, if the situation called for part of that fallopian tube removed or totally removed, or the fallopian tube suffered some damage from that ectopic pregnancy, then it will increase the birthing parent's chances of some fertility issues moving forward. So this can be a really compounding type of loss and grief. Treatment options for ectopic would include medical, where a medication is given and it will dissolve the baby or tissue. And sometimes the body even kind of reabsorbs that, or surgically, where the provider would go in and surgically remove the baby's remains or tissue. Next slide. Stillbirth. This is defined as an intrauterine death of the fetus or baby at 20 weeks or greater. So less than 20 weeks with no fetal heart tone or heartbeat would be miscarriage. Past the 20 mark would be considered a stillbirth. And the birthing parent would normally present to their OB's office or to the emergency room reporting decreased fetal movement, cramping, and or bleeding. Those are usually one of the first signs, although sometimes there's no sign. And that can be really upsetting and disturbing when you don't understand what's happening to you and your body and your baby. This may happen prior to going into labor, or it might occur during labor and delivery. Often it occurs without much warning and not a clear explanation. So again, thinking about how compounding and complicated that can potentially be for someone's trauma or grief experience. Stillbirth occurs in approximately 1 in 160 pregnancies in our country. And usually, because providers know the family wants and desperately deserves answers, they'll generally do some form of genetic or pathology testing, either on baby, umbilical cord, or placenta, to help determine a cause. According to the March of Dimes, there is less than 1% chance that a family who's experienced a stillbirth would experience another stillbirth. And treatment options for a stillbirth delivery would be expectant. So it's confirmed there's no heartbeat. We're going to let the pregnancy progress. And when labor and delivery occurs, it occurs. Or medically, we're going to go ahead and induce labor, and you will deliver with whatever medication or medical interventions that you want or deem most comfortable for you, or surgically, perhaps a C-section is offered or wanted. Next slide, please. Newborn death. This is when the infant is born and dies within the first 28 days of life. This may occur in the hospital, or it may not. Perhaps the family had already returned home with their newborn baby. This could be sudden or unexpected death, or perhaps a diagnosis had already been made, the prognosis was known, and therefore palliative or hospice care had been initiated. Some common causes may include a prenatal complication for baby, premature birth or low birth weight, a birth defect, or some sort of infection, and then in some cases, sudden infant death syndrome or SIDS, or shaken baby syndrome. Newborn death occurs in about 4 in 1,000 babies each year in our country. And again, thinking about it through that trauma and grief-focused lens, these families will likely become involved with first responders, such as EMS, or the emergency room, neonatal intensive care unit, or pediatric intensive care unit. and may require further genetic testing, pathology, or autopsy. And in some instances, for newborn death, the family may work alongside Department of Children and Family Services or local police. Next slide, please. So thinking about these very specific individualized types of losses and the mental health of the birthing parent and non-birthing parent and their loved ones. Generally, they expect that they're going to grieve and that their grief will be a deep pain, deep anguish, and that it'll probably be individual and unique to each of them in their own way, and that it's going to be intense. What's often more unexpected from a mental health perspective is how big of a change it makes in their life and their future. And that this grief that they're carrying is lifelong, because grief is love. And it's all the love they had for this precious baby and their pregnancy, and that's with them forever. It does increase their risk of experiencing depressive, anxiety, or post-traumatic stress disorder symptoms, and it is very likely to impact their daily functioning. Common emotions you'll hear them express include self-blame, guilt, loneliness, emptiness, like bodily emptiness, but also mental and emotional emptiness, anger, fear, a sense of failure and shame, sadness, and intense heartbreak. Common challenges may include not feeling safe anymore in their own body, within their environment, interfacing with healthcare providers, being around other people who are trying to conceive or are pregnant or having babies. A sense of self or identity shifting. You'll often hear birthing parents say after loss, like, I don't know who I am or what I'm doing anymore, or what the purpose of all this is. And then maybe they always envision their family to look one way, and now they're not even sure if they want to have another baby, if they could be pregnant again, if their partner wants that. And so the impact of relationship and even finances, medical expenses involved in perinatal loss can be astronomical. And then if they were provided a choice of what to do for their baby, such as a funeral or burial or cremation, all of that can be very costly. Next slide, please. So if you're a frontline inpatient worker, what I would encourage you to draw upon is the caregiving theory to providing care to them. And this is based in John Bowlby's attachment theory, where we're looking at that parent-child relationship, but we're focused on that parental side, the people in front of you. It is a parent's innate need to nurture, protect, and socialize their baby. That is what they had been planning and envisioning to do. So how do we encourage them to do that? So nurturing could look like opportunities to hold, bathe, dress, even maybe put baby to breast or chest, or allow birthing parent to pump and express milk and put on baby's lips. Think of all the things they could do for their baby. Protecting their baby could be talking about pain and discomfort for birthing parent and baby's involvement throughout that process. What procedures might be needed or not needed, giving them a choice to decide, and always maintaining that baby's dignity and integrity. And then give them opportunities to socialize. Ask their baby's name. They want to tell you. They want you to use their baby's name. They want you to reference their baby's unique traits and features. Maybe ask them if they have specific rituals or customs that they would want to do while they're in the hospital with their baby. Do they want photos, footprints, handprints to create an album or scrapbook later? What are their thoughts and ideas about honoring their baby later through funeral or burial? Next slide. And then if you're not on the front line, you're maybe an outpatient provider. You're the one who's perhaps offering the grief and bereavement counseling or therapy. I would encourage you to draw upon the 4 phases of grief by Bowlby and Parks. Again, kind of going back to that attachment theory framework, and knowing that this is nonlinear. It doesn't go in a particular order. Grief looks and feels different for every single person, and there's no real timeline for it. It's messy and intricate. But generally, the 4 phases would include some level of shock and numbness and disbelief that this has occurred. And then eventually some level of searching, yearning, and questioning. There will be a phase of some disorientation, kind of going back to the who am I? What does this mean for me? What does my life look and feel like now that this has happened? And then eventually we'll see some reorganization, right? Some adjusting to this is what happened, this is my story, and I'm trying to figure out not how to move on, but how do I move with and forward. Next slide. And then I wanted to at least share a few resources with you guys. I have some here listed for statewide resources and then nationwide resources. And then there will be a little handout too that will be emailed to you guys that's more comprehensive. But basically, to some degree, all of these offer some level of financial assistance for families, which is great with medical costs or counseling costs or even funeral or burial expenses. And then almost all of these also offer some assistance with support groups or helping get folks into counseling or therapy after their loss has occurred. And some of them even do free online counseling or peer support options. Next slide. I know that this was a lot of information in a short amount of time, and it is such a delicate subject. If you think of any questions or have any concerns later, please reach out to me. I'm an open book. I'm passionate about this work, and I'm happy to help you in helping others along their journey.
Thank you, Haley. Does anyone have
welcome.
any questions